This is John Weigelt, your coordinating editor for CSAP 17 Audio Companion. I'm sitting here this morning with Dr. Nicole Gabran, one of our CSAP 17 authors. Nicole, let's start by asking you to share with our audience a little bit about where you're located, your primary focus of your clinical practice, and maybe a little about how you spend your usual day or week, if there is one of those.
I am a burn surgeon and a general surgeon by training. I have focused my career on burn outcomes, including scarring and quality of care. My most recent efforts are to better understand long-term outcomes after burn injury, including psychosocial recovery and physical recovery, with an effort to educate both patients, families, and the public about burn injury and its sequelae. I currently have left clinical practice and am the Associate Dean for Research, and I spend my days delving into the data around patient-reported outcomes and their recovery, trying to better understand from their viewpoint what the challenges are to recovery, and also understanding the pathophysiology of hypertrophic scar formation.
Boy, that's great. Maybe we can touch on some of that as we go through the CSAP topics today. What I've asked you to share your thoughts on are topics from the skin and soft tissue category in CSAP 17. Many of these topics come directly from the questions, but others are questions that I know the committee's discussed but may not have made it into the final draft of CSAP 17, but I can tell you I've picked them because the discussion between the committee members was robust. So let's get started. I want to start, obviously, with your area of expertise, and that's burn wound care. What's most important in the initial care of a burn patient for somebody out there in a rural hospital where they end up seeing let's call it a 20% burn, at least 20 to 40% burn? What should they do and what should they know?
I think the most important part is to adequately understand the severity of injury right at the outset. And to do that, you really have to be able to accurately assess the size of the burn, which involves some calculation of total body surface area. Whether or not you simply apply the rule of nines, which is a very simple algorithm for estimating burn size, or you use the patient's hand, including the fingers, as 1% total body surface area, and in your mind roughly calculate how many hands it takes to cover the whole burn. That's especially useful for pediatric scald burns. I think one of the biggest mistakes that I've learned over the years is that a patient will have a scald burn that involves one shoulder and drips down to a apex at the base of the pelvis in the diaper, and the referring provider will say, well, the torso is 18%, so that's an 18% burn, and the patient then will arrive in our emergency room and we will see that it's a 5% or a 10% burn. And so the hand as a calculator can be very useful. The other important part of understanding the severity of a burn relates to understanding the depth, and you really cannot do that without debriding the blister. We actually at Harborview Medical Center have created a set of videos for our referring providers to use to educate them on how to debride the burn so that they can then either assess the wound bed themselves or send us a picture so that we can assess the wound bed and say, oh, that's a very shallow burn, just put some bacitracin and we can see the patient in our clinic, or that's a really deep burn. We need to see that patient as soon as possible. Obviously, for a patient with a 20 to 40% burn, we would always accept that patient. But if, for instance, part of that burn were a first-degree burn, we would be less concerned that the patient was going to have a large inflammatory response, and their resuscitative needs would be different. And so those are the two critical parts of an early assessment of the burn. I will say that it's important to remember that every burn should be considered a trauma patient first, and therefore we need to follow the rules of a trauma workup and assure that the airway, breathing, and circulation are all adequate as well.
So now we have IV access. Now, resuscitation, obviously, fluid resuscitation is critical in that initial phase as well. So are we still arguing about what the best solution and the best formula is to resuscitate a burn patient?
Let's just say there is equipoise on the solution and the volume. And we are still funding DoD projects, multi-center clinical trials, to determine what the best solution is. A new study has just been funded to understand the role of albumin for resuscitation. The whole concept of resuscitation in burn care is like a pendulum. We started with too little in the 50s and the 60s. By the time Baxter and others started developing formulas to estimate what the resuscitation fluid should be started at, we began to over-resuscitate. By 2000, Dr. Basil Pruitt was writing about fluid creep because we were dramatically over-resuscitating patients with crystalloid, causing incredible complications. A patient who had excessive fluid resuscitation with an inhalation injury has about a 15 times fold risk of having ARDS than a patient who is not over-resuscitated. And so the morbidity from over-resuscitation was dramatic. At some point in the last 10 years, the popularity of plasma has increased again, and albumin has been reintroduced to the algorithm. There is one fun tool that has been introduced, and it was developed at the Institute for Surgical Research, which is a bedside computerized decision tool that allows you to estimate what the fluid should be and then plug in on an hourly basis how much the urine output is and how much fluid they were getting, and it will respond with a recommendation for whether you increase the fluid or decrease the fluid. It's actually a fun tool that reduces some of the guesswork, and it also, I think, forces the bedside staff to pay greater attention to the hourly fluid balances. The one caveat and the one place that you can get into trouble with this is that it doesn't take into account the hyperglycemic response that many patients develop during the inflammatory or resuscitative phase. And as a result, if the patient has a huge amount of urine output or diuresis due to their hyperglycemia, the instrument will advise you to decrease the IV fluid, and you actually get into a situation where you actually have intravascular hypovolemia because you're not keeping up with the osmotic diuresis.
Let me change the subject a little bit, but still in the initial care, and that is we haven't had an escharotomy question in CSAP 17, and this time we do, including a video. Any hints about doing escharotomies, when to do them, how to do them from your perspective?
I think it's very unusual to need an escharotomy within the first 8 hours. Of course, rules are made to be broken, and there are some patients who do become swollen and do benefit from having the burn incised. because really many full-thickness burns become like a carapace of a crab or a lobster and don't allow the muscle compartments to swell. The biggest problem that I see with escharotomies, truthfully, is that people do them too deep. There's no benefit to making the incision into the underlying subcutaneous adipose tissue. The adipose tissue does not form a band. It doesn't prevent the expansion of the muscle, and the fascia is not involved in most third-degree burns. The only time I would worry about needing a fasciotomy is if the patient were to have a fourth or a fifth or a sixth-degree burn. The problem is that these have terrible, terrible cosmetic results downstream. And so in patients who have had escharotomies, either because they were symptomatic or because they had evidence of poor blood flow, if those wounds have by chance healed, they will always have a linear scar down the extent of their extremity, or if they need a torso escharotomy, along the sides of their torso, their chest, or their abdomen. And those are unsightly and they can be bothersome to the patient.
There was some talk a while back about you could use enzymatic agents to affect the same thing as an escharotomy. Is that still in vogue, or has that fallen by the wayside?
There is certainly interest in enzymatic debriders. In fact, there is a novel product that has been approved in Europe. It is under investigation still in the United States and awaits FDA approval, but they are undergoing several studies. There's a recent study that was finished in adults, and there's an ongoing study in children, and that is being touted as a means of avoiding escharotomies and debriding some of the dead tissue early after the injury. So I think that the results are not in on that, but there is some enthusiasm, and it has been touted, for instance, as a means of burn treatment even in a disaster situation.
Now, you kind of mentioned inhalation injury in relationship to over-resuscitation. Is there anything else we should know if the patient appears to have an inhalation injury? Do we alter much of our initial care?
Our ability to diagnose inhalation injury is not perfect. We are still looking for a magic diagnostic tool. I think that most people now would consider bronchoscopy to be the best way to diagnose inhalation injury. And some of the interesting data that came out of Loyola about 10 years ago was that bronchoscopy early after admission for an inhalation injury has a very high rate of positive bronchoalveolar lavages. And so the opportunity to identify an early pneumonia gives you the option of treating that earlier and not developing an early ventilator-associated pneumonia. The ability to score the severity of the inhalation injury based on bronchoscopy has certainly been looked at, and I would say that the scoring systems are not perfect and are still subject to some subjectivity, and so they are difficult to reproduce across sites. And so we really don't have a great way to standardize our assessment of inhalation injury at this time.
With that device that you talked about how to judge our resuscitation, has there been enough evidence or been enough experience with that device to help us in the resuscitation of a patient with an inhalation injury?
We probably collectively, between the long history of use at the ISR and also at more and more civilian burn centers, could collate the data, but I have not seen an analysis where they have used the data from this computerized decision support tool to look at resuscitation with and without an inhalation injury. It's a great study that I'm going to bring back and recommend that someone do.
Do I get some credit for that?
Absolutely.
Okay.
You can be first author.
Oh, yeah. Let's move on a little bit. And once you have that burn patient in your burn center, is early excision still the goal?
My colleagues here at our burn center are pushing early excision beyond what even my mentor, David Heimbach, would have touted. When we looked at our rates of excision, we found that most of our patients over a long period of time underwent surgery on day 4 after their burn injury, and we considered that early. We actually considered anything within the first 7 days to be early. We are pushing that to the limit based on experiences with the ability to excise the burn safely, even during the resuscitation phase. And so I'm seeing more and more that surgeons are taking the patient to the operating room within the first 24 hours to try to remove some of that inflammatory eschar.
And the reason for that is, you got any ideas, or is it just that we have the capability to doing that safely at this point?
Well, I think that the overall philosophy would be that you control the inflammatory drivers of SIRS and you control the resuscitation. For many years, we were worried that it was unsafe to resuscitate the patient in the operating room while you were also dealing with the blood loss associated with excision of the burn. But I think that more and more we are appreciating that we can resuscitate the patient and keep up with blood loss from the surgery if we are working in a good manner with our anesthesiologists and communicating well about the patient's status. And so I think partly it has to do with patient safety. And we've known for many decades that if you remove the eschar sooner, you can control the inflammatory response. That was shown in dogs, and many of our surgeons nationally have advocated for that. But it was really a concern for safety in terms of getting the patients through the resuscitation phase. And so I think that we're going to learn more as we move on, and that it's going to require some loop closure to see how patients are doing. But I think that it's certainly worth looking collectively in a multi-center fashion at the effect and the timing of early excision.
Let me ask you a question that just jumped into my mind. The coverage after excision is usually split-thickness skin grafts or full-thickness grafts or skin substitutes. Are you worried that if you're excising during resuscitation that your graft loss will be increased because of microcirculatory inadequacy?
I don't think that most surgeons would take the time for a patient with a big burn to actually put split-thickness skin grafts on at that time. The options would be to either use a temporary biological dressing such as allograft or a xenograft. In this country, xenograft is most likely to be pigskin. Or in Australia, John Greenwood has had good luck applying his skin substitute, which is a novel urethane, I'm pretty sure it's urethane-based dermal substitute. And he would apply that directly at the time of the excision of the burn. And that actually gets the process of wound closure started, because that would begin to integrate into the wound bed. And the clinical trials and the consensus of people who have been using his skin substitute is that its infection risk is lower than some of the other skin substitutes that have been on the market.
Okay. Now, we do not have a question on skin substitutes in CSAP 17, although we did have a couple of committees discuss it. So are we closer to the ideal skin substitute today?
I would have thought in the mid-90s that we would be much further along than we are. I would have thought that by 2019 we would have had a bilaminate skin substitute that would be readily available that we could access easily, and we are not there yet. The exciting product that is now being integrated into people's practice is a autologous sprayed-on cell suspension that allows you to, in the operating room, take a small biopsy of skin and process it using enzymatic debridement or enzymatic tissue breakdown on the back table, and then put it in a little spray bottle and spray it onto deep partial thickness wounds, or very excitingly, I think, onto the interstices of widely meshed grafts, so those interstices close more quickly. And I think that that is one of the exciting current tools that burn surgeons are integrating into their practice.
Let me ask you, in burn surgery, is negative pressure wound therapy creeping into your practice like it is in most areas of surgery?
I would say that it has been used for probably the past 15 years to help with wound bed maturation if the wound beds are not perfect, especially for deeper burns, to try to increase vascularity in those wound beds. Sometimes it's used to help meshed skin grafts adhere more quickly. One of the advantages, actually, that I have found is that it's a really nice way to secure a skin graft and prevent shearing. Whether or not there actually is a benefit to accelerating vascularity or accelerating adhesion, just the fact that you're stenting the skin graft for a period of time and allowing it to remain untouched so that it can't shear with mechanical forces has an advantage. In deep wounds, there might be a role for promoting some tissue growth and some granulation tissue to get a wound bed that could be grafted. And again, for skin graft immobilization, there is a role.
Let me ask you, with your research background, Nicole, this business about what the benefit of negative pressure wound therapy really is. You mentioned increased vascularity, which is certainly something that has been touted related to even the incisional vac, that it improves the ingrowth of vascular structures or the healing phase with vascular ingrowth. Do you have any thoughts related to whether you think that's true or not?
I'll be very honest, I haven't reviewed the literature on that topic specifically for a while. Certainly there have been some studies in animals and in people that suggest that vascularity after placement of a wound vac is increased. Of course, many of us believe that vascularity in a wound bed and granulation itself is a risk factor for hypertrophic scar formation. And so all of that beefy red granulation tissue that's full of inflammatory cells and probably bacteria ultimately becomes proud flesh and is a precursor to scarring. And so for many burn surgeons who want a decent wound bed once they get that granulation tissue growing in so that they know their wound bed is viable, they will not graft onto that granulation tissue. They will scrape it away. And so the fact that the wound is able to grow that vasculature means that it's viable, but I'm not sure that the granulation tissue is desirable underneath a skin graft or as a ultimate wound for the scarring effects.
Well, let's ask you a little bit about, you mentioned about your research with evaluation of wound and hypertrophic scarring. Are we better at preventing and limiting scarring after we excise a burn and graft it? Are we making advances in that area?
Again, I would say that I would have hoped that we would be further along in what we have in our armamentarium for treating or preventing hypertrophic scars than we are now. The one tool that has emerged and really become popular again over the last 10 years is the fractionated CO2 laser. And for whatever reason, and it's not clear to me from a pathophysiology reason why this happens, but putting these little wounds into the hypertrophic scar in sort of a tic-tac-toe pattern is very effective at controlling some of the vascularity, some of the wound depth, and for many of our patients, the serious complication of itching. It's not clear to me because many people will perform this and then will treat the wound with topical steroids, whether or not it is due to the fact that these little holes just provide a better conduit than through the stratum corneum, or whether or not re-wounding the scar tissue in the mesenchyme is actually reprogramming the mesenchymal fibroblasts and other dermal cells to do something different with their remodeling. I think it's very exciting that the patients are as pleased with the results that they are getting, but we still have no clue what the pathophysiology is, in my opinion.
Now, you also kind of mentioned you're looking at outcomes after burns, and certainly in the trauma world, I'm dealing with how to prevent PTSD. Is it a similar effort that you're going through in the burned population?
Certainly, PTSD is one of the areas that we're concerned about preventing. I think that we know that patients who have acute stress disorder in the hospital are at higher risk for PTSD down the road. And so screening for either depression or acute stress disorder while the patient is in the hospital or early after their injury is really critical, because an intervention early can often prevent the later PTSD. I think that's something that we as health providers need to be helping our patients with on a regular basis. Routine screening. It's very simple and can be done very quickly and then result in a referral to a mental health specialist or a behavioral specialist. Really, what I am interested in is quality of life after burn injury. And when we look at data from patients who we have followed for 2, 5, and sometimes 10 years after injury, we are seeing that they report a lower quality of life than the general U.S. public. I think that this provides us an opportunity to develop support systems. One of the things that burn surgeons are a wee bit better than trauma surgeons at is following our patients long term. But long term for most burn surgeons is about a year. I think what's clear from the emerging data is that our patients are struggling with recovery for many years, suggesting that a burn injury is a chronic condition. And patients still have questions about whether the burn, whether the inhalation injury is why they are having belly pain or chest pain or other symptoms late after the injury. And so we need to develop systems to allow patients to get the answers to those questions during their recovery period and beyond.
Let me change the topic a little bit, but also with a burn injury that sometimes leads to long-term complications. And that's, we do have a question on electrical burns. And let me ask you, so you have a patient who you know was working on a high voltage line, had a contact, comes into the emergency room with a contact point on one of his hands and another contact point on his foot. How do you evaluate that patient for significant electrical injury between those 2 points?
Well, obviously you have to go back to the ABCs because depending on the injury, you need to know whether or not the patient had a loss of consciousness, whether or not there was any head trauma, the usual trauma workup, right? And you have to be concerned about whether or not there was a significant cardiac contribution to their loss of consciousness. And so I think that most patients with high voltage injuries should be monitored for 24 hours on telemetry or in an ICU situation to monitor for arrhythmias and to check troponins. So that's one way to assess the systemic effect of the electrical injury. And then serial exam. Certainly it's helpful if the patient is awake and alert and you can elevate the extremities and do serial exams. If you can't, you need to consider whether or not you should be checking compartment pressures if you are worried that there is a significant muscle injury. I think probably the biggest neurologic assessment or the most important neurologic assessment in a patient who's had a high voltage injury with tissue injury in the hand is assessing their carpal tunnel and their median nerve, because that tends to be an area that gets swollen very often, and it's relatively simple to decompress the median nerve. And so that should be an area of focus in any evaluation of a patient with a high voltage electrical injury. Of course, you can check for rhabdomyolysis, and if the patient has dark urine, then they should be resuscitated a little bit more aggressively than they might be if they do not have visible rhabdomyolysis or myoglobinuria. A lot of people these days are actually checking levels, and you could be surprised at how high the levels are when the urine is absolutely clear. And our policy has always been that if the urine is clear, you do not need to treat the patient as if they had myoglobinuria. But if the urine is pigmented, then we would increase the IV fluids to increase the urine output. And even though it's unclear and there's not a lot of evidence that it has any beneficial effect, alkalinizing the urine is relatively harm-free and doesn't have a lot of downsides. And so it may promote diuresis of the pigments.
Long-term outcomes, mental changes, and risk of cataracts, is that still operational?
I think that all patients need to be screened for cataracts, both immediately after the injury and then if they do report eyesight changes. I've actually only seen cataracts in one patient with a high voltage injury, and he developed them within 2 weeks of his electrical injury. But it's very rare. I think that we underestimate also the mental health effects of an electrical injury. And so it's worthy of screening patients for depression, change in mental status, and cognitive changes after they have recovered and been discharged from the hospital.
Let me switch topics to a favorite topic of CSAP, which I know you've seen many test questions on soft tissue infections. And they always seem to end up discussing the Lernick score, the LRINEC score. And this last January, there was an article in Annals of Surgery that questioned whether it's as good as we thought. I don't know if you've seen that article, but any thoughts? Is this score really helpful for us to evaluate a patient for a necrotizing skin and soft tissue infection?
So I think that there have actually been several papers in the last few years that have concluded that there is no score or radiologic study that is a litmus test for whether or not the patient should have surgery. There are some people who would say that if the Lernick score is lower than 6, that the patient doesn't have necrotizing fasciitis, but the meta-analyses would suggest that there are patients who need to be excised and debrided who have low scores. And so I do not think that it is an indicator that is helpful when a physician is making the decision to operate or not to operate. I think that it probably has a value in assessing and standardizing the severity of the injury in a post hoc fashion when one wants to understand whether or not an intervention A, B, C, or D has an effect. But I think in terms of a tool to make a decision about going to the operating room, I think that most experts in necrotizing fasciitis would agree that clinical judgment is still the best way to decide whether a patient goes to the operating room.
I don't think I'm a clinical expert, but boy, my clinical acumen tells me I agree with you completely. So that makes me feel pretty good, to be honest. Let's talk about Group A strep infections. This was a popular topic, and I guess my first question is this because we're seeing more of these?
I think it's hard to tell because regionally it's so different in different communities. What I would say is that if you look at any review of the pathophysiology of necrotizing fasciitis or necrotizing soft tissue infections, Group A strep is one of the most common etiologies of both multibacterial and also single bacterial causes of necrotizing infections. And so for that reason, I think it really remains relevant. It by far is the most common contributor to multibacterial infections and also single bacterial infections. And so it definitely needs to be considered when one is choosing one's antibiotic regimen.
So besides early debridement and appropriate antibiotics, there's been a lot of talk in older papers and newer papers about hyperbaric treatment and gamma globulin administration to that Group A strep patient. Do those two really add anything to our management approach?
What I can say is that a recent Cochrane analysis suggested that review of all of the papers about hyperbaric oxygen over a very long period of time were not convincing, and that even though the results of many of those papers advocated for the use of hyperbaric oxygen, the conclusion of the meta-analysis was that they were largely biased and that the data supporting the use of hyperbaric oxygen is not strong. Most papers on this topic end by saying we have a strong need for randomized controlled trials for both gamma globulin treatment and hyperbaric oxygen treatment. And so I think that the jury is still out on both of those. I suspect that especially with anaerobic infections, the hyperbaric oxygen is justifiable if the patient is not too sick to be placed in a hyperbaric oxygen chamber, which, by the way, for a very sick patient can be a potentially dangerous place to be. It's not as if you are able to quickly decrease the oxygen pressure if they have a complication or need an intervention. And as with any change in pressure, the risk of a pneumothorax or the inconvenience of a tympanic membrane rupture can be morbidities. I would say for hyperbaric oxygen, the data are not good, and the same is true probably for gamma globulin.
Now, I realize you're not in the southern U.S., but there's really a great question about Vibrio infections with a great critique in CSEP 17. You got any thoughts on these infections?
I've never seen one. I will say that when my patients with burn injuries ask me whether they can go swimming, I say don't go in a mountain lake or a mountain stream, but you can go into the ocean. And one of my fellows was horrified a few years ago because he thought that the patients would all get a Vibrio infection. And so I think that it is true that it is a risk for patients who especially are cut when they are walking in an ocean setting or a marine setting, but it is one of the more rare forms of necrotizing fasciitis, and I have no experience treating it.
Let me ask you a question about something I know you've got experience with, but MRSA infections seem to be old news. Are we still seeing these as often in the past, or are they slowly disappearing with, better preventive care or better understanding of them? And any change in your approach if you're still seeing these?
I think they are less talked about because we're becoming inured to them, and they are just part of what we are dealing with. I think that based on recommendations for perioperative antibiotic management and perioperative screening, they still are a significant problem in the community with rising incidence. And I just think that we are more used to them and are focused on other types of resistant bacteria that we may not be as comfortable with. And so I do not think that the MRSA problem has gone away. I just think that we are becoming more accepting that it's part of our daily routine.
Let me ask you a question about the University of Washington. Do pre-op patients get screened for MRSA routinely?
Yes, the elective surgeries have nasal swabs as part of their routine preoperative planning, anticipating that they would need vancomycin as an additional perioperative antibiotic. And our protocol for necrotizing fasciitis de facto includes vancomycin until MRSA is ruled out. We still consider MRSA to be a potential problem for our infected patients.
Just out of curiosity, do you ever try to decolonize any of those people with bacitration or any other agent?
I guess we would do it with Bactroban. I think that we have instituted Bactroban nasal treatments, but it is not hardwired into our practice, but that it is theoretically a recommendation with either that or, if I'm not mistaken, povidone swabs are an alternative approach to nasal treatment for MRSA.
I misspoke there. It is Bactroban, not bacitration. My brain was ahead of me, so actually my mouth was probably ahead of my brain. So
I corrected you because it's one of my pet peeves that very often community providers as a first-line therapy will use Bactroban rather than bacitracin. And my worry as somebody who deals with a lot of breaking down wounds is that if we use Bactroban in a non-judicious manner, we're going to have MRSA that is resistant to Bactroban, and then we won't have a good topical agent for MRSA. And so one of my, as I said, pet peeves is that we should be careful about using Bactroban indiscriminately.
Good point, and there actually are reported strains of MRSA that are resistant to Bactroban, so it doesn't take long to develop that kind of problem, so good point. Well, let's change topics, and I'm going to be fascinated with your response to this question. But again, hidradenitis suppurativa was very popular for a topic leading to a CSAP-17 question. And we've got one question that asks about the relationship of hidradenitis to pyoderma gangrenosum and other autoinflammatory skin disorders. You got any thoughts about this?
I think actually the association between hidradenitis and other autoinflammatory conditions is going to open up the doors for us to better understand an orphan disease that historically no one has wanted to own. From the surgical standpoint, it's a difficult disease to treat because of its chronicity and the sheer misery that the patients undergo through, both in terms of chronic drainage, isolation, chronic pain, and ultimately an increased risk for squamous cell cutaneous cancers consistent with other non-healing burn wounds, etc. But if we are better able to understand the genetics, for instance, because we can associate this condition with other vasculitides or other myeloid dyscrasias, it might give us an opportunity to promote precision medicine or personalized medicine for these patients. One area that I think is particularly intriguing is the recognition that some of the anti-TNF-alpha therapies with unpronounceable names, adalimumab and infliximab, are actually having some positive benefit on patients' quality of life for patients specifically with severe hidradenitis. So I think that shows some promise for these patients who have truly expressed misery due to their conditions.
Let me ask you about surgical therapy and especially excisional therapy. When you have that patient who comes in with multiple burrowing tracts and they're just miserable, you've tried everything, the dermatologist has tried everything. Do you have any experience with excision, split-thickness skin graft, and whether or not that's a curative approach, or is it just another temporizing approach to, as you mentioned, a chronic disease?
Since I don't understand the pathophysiology and what is actually driving the generation of the sinus tracts, for instance, it's not clear to me that just excising the superficial epidermis and putting a new epidermis will help the patient. But I do think that anecdotally we have seen that patients who come with terrible suppurative draining wounds who have a deep excision, a full thickness excision, maybe even through down to the adipose tissue, removing some of the adipose tissue if it's showing inflammation, and then having a skin graft, they do have some relief, and many of them are very grateful for the improvement in their hygiene. And those wounds do seem to be stable over time. And so I do think that there is a role for surgery, especially for patients who have severe hidradenitis. But I suspect that it needs to be in combination with other pharmaceutical modalities.
Let's talk about something that you mentioned right at the beginning of our discussion, and that is We do have a question on keloids and hypertrophic scars. And I guess my first question is, are they different?
I do think they're different, and it's how they behave, especially since hypertrophic scars do have a biphasic response. They will get worse for about 6 months after the injury, on average, and then they will never return to normal-looking skin, but some of that inflammation, some of that increased vascularity, some of the raised tissue will begin to resolve as remodeling occurs and as the scar matures. In contrast, a keloid just keeps growing and it never resolves. Even if it matures, it remains like a cauliflower growth on top of a small wound. And one key differentiating factor which needs to be remembered is that a hypertrophic scar always stays within the boundaries of its original wound. It never has that cauliflower-like growth that exceeds the boundary. A pockmark from a acne or from an earring hole would have a little raised area, but it would always be within the confines of the original tissue injury. Unlike a keloid, where you can have a golf ball size growth from a hole in the ear or from a chicken pock mark or from a pock mark on the face.
So do we have any reasonably successful treatment for either of these conditions?
Well, for the hypertrophic scar, I do think that the fractionated CO2 laser is offering hope, and it has shown promise, again, for it to be widely accepted as a treatment. I think it's going to require a multi-center clinical trial that is objective, because I do think that probably some of the early reports about how successful it is are optimistic and are anecdotal rather than showing good science. And so we need more numbers, we need more evidence, but it is rapidly being integrated into everyday practice. I can tell you one anecdote of a child that I treated many years ago who for 5 years after his burn had itching that was so bad in his scars that he had large excoriations where he was scratching his hypertrophic burn scars. And we had tried everything. And he had one laser treatment, and I happened to see him in clinic. I was just walking through the clinic a week after that, and he ran up to me and gave me a huge hug and said, "No itching," after one treatment. It was the first time in 5 years he had had no itching. And so I think that we need to know more about what it's doing, how it's doing it, and see whether we can understand what the effect is on hypertrophic scarring.
I realize I've known all about itching and hypertrophic scars, but I never thought that, do keloids itch?
I don't know. No one has ever told me that they itch.
Okay, well, I have seen people with keloids and they haven't complained of that, but I've never thought about it until just right now. So how about successful treatment for keloids?
Well, again, I think that the fallback, and it's not a great treatment, is excision and then immediate radiation therapy. And of course, that has limited efficacy. There's some interesting research out of Stanford with regards to pathophysiology of scarring, and it relates to tension. If you can offload the tension from your wound, you can significantly decrease the amount of fibroproliferation in the wound and decrease the amount of scarring. And so there's some recommendation that even for incisional wounds, you, in addition to suturing the wound shut or closing it in a tension-free manner, prevent the pulling on the wound edge by either using an expensive device that pulls the adjacent tissue towards the wound edge so that it doesn't pull on the wound, or I just do it inexpensively by using some tape that I adhere away from the wound edge and then advance both sides so that there's no tension, and I continue that for several weeks even after the incision has healed as a means of reducing the tension. And if you think of body sites that do form fibroproliferative scars, it's always in areas where there is significant contraction. So you rarely see hypertrophic scars on the scalp. You don't tend to see them on the soles of the feet or the palms, but you do see them, for instance, over the presternal chest where there's significant amount of contraction around the sternum.
Well, I've got one final question that I'd like to go over with you, and that is a question that many of the committees discussed, and it relates to perioperative infection and smoking cessation. And I know that you've got some colleagues at UW that are big on surgical infections and their prevention. So what is the practice at UW regarding patients who come in for elective operations who have a large smoking history? And do you insist on smoking cessation? And then the other question that the committee struggled with is, what kind of duration of abstinence does it really take to restore normal pulmonary function and to really reduce SSI rates once the smoking stops?
Let me backtrack a little bit because I, again, think that it's not just the smoke that is considered to be concerning. And so the debate as to whether or not you can use a nicotine patch is also unresolved. And so for a patient who has a nicotine addiction due to smoking, there are some surgeons who say they can have a nicotine patch, and there are other surgeons who would eschew that approach. I think that to some extent, the choice of whether or not to operate on a patient who has a strong smoking history is still surgeon dependent. We certainly encourage patients to give up smoking, and I would say that many of our plastic surgeons who truly do elective surgery would have a more rigorous requirement that patients give up smoking prior to aesthetic surgery, for instance. But I am not aware of an absolute refusal to do elective surgery at our facility if the patient continues to smoke.
Do you ever talk in M&M about the pulmonary function issue, and if you're going to stop, how long you need to stop before your pulmonary function, your ciliary function returns to normal?
We do have a checklist. When a patient develops a surgical site infection, the residents dutifully post the checklist that includes many of the risk factors that are thought to contribute to surgical site infections. And smoking is on that list, but the number of times that we have actually debated how long and what the ciliary function is has been unusual. And so I don't think that that is something that people entertain in their daily practice.
Well, it was interesting. The committees were split on 2 weeks versus at least 4 to 6 weeks. So those were at least the answers that a couple of the committees came up with. And when you try to find the evidence for that, it's not crystal clear. Let's put it that way. So
I think that the fact that a recent Delphi survey was published, and if I'm not mistaken, I think that Patch Dellinger was an author of that survey. The experts in surgical site infections identified smoking as an area that is worthy of research for SSI prevention. And so I think the experts in surgical infections would still see that smoking, as well as nutritional status, obesity, technique, and other risk factors, are worthy of continued research. And so I guess that would suggest that they have equipoise in what they think are the relative risks.
Well, as usual, Nicole, it's great sitting here discussing these issues with you. I always learn something, but I see our time is up, and I would offer you the opportunity to comment on CSAP or the process of CSAP or CSAP Audio Companion, especially as we enter this new world of continuous certification from the American Board of Surgery.
I think that the current culture of MOCs is a fascinating one, and I have never been a huge fan of the every 10-year exam that is not really an adult learning experience. So I have always felt that CSAP is really an incredible tool for the surgeon, especially the general surgeon, who has to be responsible for a broad breadth of expertise, to keep current and be able to learn in an active manner. When I was preparing for my last MOC and I used the CSAP online testing system, it was so easy, and I felt like I had actually learned something about areas where I don't routinely practice. I'm not a breast surgeon anymore, and so the ability to learn to take the question, read the answer, and ultimately take it officially was a really nice advantage. And so I have really valued CSAP as a learning tool for myself. And it's also a lot of fun to participate in the development of the questions and to be involved in the debate as to whether or not the question is a good one, or whether or not it's too detailed, or whether or not it's too broad. It's always fun to see what bubbles up as a question that is vetted and determined by a broad group of experts to be of sound educational value.
Well, I thank you for those comments. Obviously, I'm biased, but I couldn't agree with you more. And I thank you for your contributions, not only today during our discussion, but to the CSAP process. And so thank you very much.
Thanks for your leadership, John. I know that it's been a labor of love. Thank you.
That's it for this category of the CSAP 17 Audio Companion.